Alright, so here's our next PEDS talk. This is an MSK talk. Start right out with a common comparative this versus that, right into the pelvis. So this is probably the easiest comparative case that you can do in PEDS. We've got three pelvises and we've got abnormalities on each one of them here. So let's take a look. This guy here looks like that he's displaced up and out, sort of up and out of the way. So that's a developmental dysplasia of the hip. Look at this acetabulum right here relative to that one. It's too high up. See the difference there? There's flattening of this femoral head, right? So that's Perthes. And then here looks like that is slipping off. So that is Skiffy, right? So let's do some trivia. All right, so here's our first case, and we said that this was developmental dysplasia, right? This is this angle is too much. We've got too much here. So what are some of the risk factors for this? So it's think about two major things. The first one is crowding. So if you're in utero and you're crowded in there, this is more likely to happen. Well, who gets crowded? People who are breech, people who have twins or quadruplets or those kinds of things, people who have low amniotic fluid would sort of crowd you in there. You don't have enough room to swim around. And then the second thing to think about is estrogen, which creates laxity. So it's more common in females. Now, the normal acetabular angle is less than 30. So this one would be less than 30. This one is clearly more than that, right? And this actually decreases with age. So this one, we've got flattening of the femoral head, and we said that was Perthes. So when do you typically see that? What's the time frame, and what's the demographic? So this is a white person, 5 to 8. And how often is it bilateral? About 10% of the time. So not that often. It happens, but not that often. And that is in contradistinction to this one, which is Skiffy, right? And the age for this person is older, fatter, and blacker. So it tends to occur more in black people than white people. Tends to occur in overweight kids, and it tends to occur in like 12-year-old range. And how often is it bilateral? About twice to 3 times as much. So older, more often bilateral. You could remember bilateral B for black, if that's helpful for remembering that. And I only point that out for the purpose of, like if they give you race in the question stem, they're usually giving it for a reason, because not every question stem mentions the fact that they're white or they're black or they're Asian or they're Latino or whatever. If they're putting that in there, it's for a reason. So that's why it's helpful to sort of remember that this is, you only see this in white people, like CF, or they tell you that it's a black person, it's a sickle cell patient or whatever. That's why it's helpful to know that. All right, so I've done this once already. You probably saw me do it, and you've probably done it yourself a bunch of times. But just to remind you, there's this line that you draw here, this thing, and that's supposed to intersect the femoral head. And when it doesn't, that's abnormal. And that line has a name. It's called Klein's line. This is supposed to be more sensitive on a frog-leg view. Now, another thing that you can do for screening on this thing is, let's say that the pediatrician did a physical exam maneuver and they heard a clunking noise, and they get these ultrasounds. So you have to do these ultrasounds. So get this anatomy sort of going. And here's a labrum, your cartilage, femoral head. You draw an angle like that. That's an angle. So that's your alpha angle. And that is different than your acetabular angle, which was this angle here. So Shenton's line, all these different lines, Perkins line, Hilgenreiner's line, and then, the ideal location is right here, okay? That's where you want it to be. And that's your angle right there. And that is, whereas your alpha angle, so this one less than 30, you want your alpha angle to be more than 60, and like those together add up to be 90. So that, like this right here. Now, some people get these confused as far as remembering, well, which one's the big one and which one's the small one? So remember that the alpha angle is the alpha male, and therefore the bigger of the two angles. So if you remember that one is, remember that they add up to 90, one more than 60, and the other one less than 30. The alpha angle's the alpha. But don't get it twisted. DDH is actually more common in women, right, because of the estrogen, not alpha males. All right, so next case, another hip, but this time, instead of being displaced up and out, it's displaced down. So pointing out the difference here, so sort of down, maybe down and out versus up and out. That's a difference between a septic joint and DDH. You can also notice that this acetabular angle is nice and shallow here. So you're suspecting a septic joint. What's your next test? So this would be like a next step type of question. You would get ultrasound. Unfortunately, you have to get ultrasound. And this is a mistake a lot of people make, is that they start measuring up in here, thinking that that's where the fluid's going to be. That's incorrect. Calipers are on here. You measure here for the fluid. That's where the fluid is. All right, moving out of the pelvis, going to move into the knee. This is an Aunt Minnie right here. And if you having trouble remembering the name, notice that there's tibial vera. There's a varus deformity here. So this is Blout's disease, also known as tibia vera. It's seen in early walkers, often overweight, and this is also more common in African American people. They're not completely sure, it's not well understood. The mechanism that you'll read about most commonly is this idea of too much weight on an immature physis. That's why it's like early walkers, like especially overweight early walkers. So too much weight on an immature physis. Also notice that the angulation is taking place at the metaphysis here, so that's important also. The angulation's not at the knee. The angulation's like down here at the metaphysis. These things are often bilateral. It can occur at several different age groups, but it's so there's like an age that's, it can occur around 2 or it can occur around 12. It's much more common to occur around 2. But it does not occur before the kid starts walking. Remember, it's the mechanism, supposedly, is, too much weight on an immature leg, so you have to actually walk on it to stress it. So it does not occur before 2 years old. So the way I remember this, 2 and 12, not before 2, and often on 2 sides, so bilateral. All right, so this is another thing here that sometimes people mess up. So we've got a lesion here, and we've got another lesion here. Obviously, they look a little different. This one looks like somebody took a bite out of it. This is a so-called Wimberger sign of syphilis, as opposed to Blout's, which we just looked at. All right, next case. We'll point out something here, which is that hint. It's a hint. And then we'll do a zoom up. And you'll notice that there's a periosteal reaction. So if you're really on top of things, you'll say that that's from prostaglandin therapy. But you can have periosteal reactions from a whole bunch of different stuffs. Torch infections, cancer, neuroblastoma. It can be a sign of child abuse, Caffey's disease, if you believe in such a thing. And then there's also the so-called physiologic periostitis of a newborn. So some trivia that's worth knowing. Syphilis is seen later on, like around 2 months, as opposed to rubella, which is seen earlier. And the way that I remember that is R comes before S in the alphabet, Q, R, S. So you see the R earlier than you see the S. Caffey's disease, if you've never heard of that before, that giant volume of pediatric textbooks that you may have seen in your pediatric reading room, that's Caffey. That's the Caffey guy. It's probably bullshit. There hasn't been a case of it in like 100 years or something. But when it does happen, well, the pictures that I've seen in books are of the mandible. But it's an alleged thing. Just because it hasn't happened in 100 years doesn't mean it won't show up on your boards. Prostaglandins, they're probably going to show you the heart, maybe with a PDA clip or something in there, because prostaglandin therapy is used to keep the patent ductus open. NSAIDs are used to close it, indomethacin. And physiologic, that's loaded with trivia, so let's talk about that. So physiologic pericystitis of the newborn is not actually seen in a newborn. That would be a very excellent trick because the name is very misleading. It's seen around 3 months of age instead, and it should resolve before 6 months. So there's a very brief window there where it's, quote, normal. The proximal involvement, like the femur, is supposed to come before the distal involvement. You should not see it in the tibia before the femur. And it always involves a diaphysis of the bone. All right. So yeah, they, don't call it this, in a 1-month-old when they've actually got child abuse. 3 months. All right, next case. Great case. So 2 weeks ago and then today, notice that we've developed a lesion right here in the metaphysis, and it occurred over a 2-week time period. So there's nothing else that can do this. The only thing that can do this is infection, right? So it's very short, aggressive process. Was recently normal, now it's not. Unlike a fat old diabetic that gets osteomyelitis from stepping on stuff or having an ulcer, kids tend to get hematogenic spread. So, and this is where it ends up, is right at the metaphysis. So if you got an MR, post-contrast, see something like that, looks just like an abscess, right? Notice that it's sort of blocked off by that physis. So I like to think of the physis as the metaphysis as a septic tank because of that physis sort of blocking that off. So it gets a lot of blood flow and then it gets stopped like right there. So that's where infection goes. That's also where cancer goes. So it's common to get a cancer to land right in the metaphysis as well. Hematogenic spread of malignancy. So let's do some vocabulary. We've got our infections gone through, stopped at the septic tank, and there's our abscess right there. And over time, it smolders and grows bigger. You might end up having a dead piece of bone that ends up in the middle, called a sequestrum. And then you've got a sort of periosteal coat that goes along the side there. Some people will call that an involucrum. And you can even have a channel that forms and bursts through, like a cloaca for like a bird. So abscess, sequestrum, involucrum, cloaca. So the involucrum's like the coat. It's a cloak of new bone. The sequestrum is like a dead piece of bone. It's like an island in the ocean there. All right, so next case, this is just showing the difference between a lucent metaphyseal band and a dense metaphyseal band. Now, there's a long differential you'll read about for each one of these things, like 30 things each. But the two that I want you to remember are lucent band, leukemia, dense bands for lead. Okay, so those are, I think, the most likely ones to show up. Lucent bands can also be neuroblastoma, rickets, osteomyelitis. Dense bands can be chronic anemia, like you'd see in sickle cell thalassemia, methotrexate, or growth arrest band, like in JRA. But memorize the long list if you want, but these are the two that I think if you knew any of them are the most likely, most classic. All right, next one. This is another ant mini, cupping or fraying right at the right at the right at the wrist. Sometimes you'll see this at the knees as well. You can see a little bit of it here. So it's multiple bones. So when you see multiple bones like that, you're thinking about something metabolic. So this is rickets. Why does it occur there? It targets rapidly growing bones. You get this cupped or frayed appearance. An important point is that it's not seen in newborns because the newborns are still using their mom's vitamin D. So if you do see it in a newborn, you're thinking about something else, right? So you're thinking about hypophosphatasia. Uncommon thing, but that would be the way that they could ask it, knowing that it looks just like rickets, but rickets doesn't occur in a newborn. This does. So all right, next case is another ant mini. This is a guy who's missing some fingers. He looks like he has a thumb, and that's an important thing to look for. Also notice that he has a radius. So this is amniotic band syndrome, like literally somebody chopped this person's fingers off. Somebody, I mean, by an amniotic strand, and it creates constricts blood flow, and it amputates the fingers. Amniotic band syndrome can cut the whole arm off, can cut the head off, can do all kinds of terrible stuff. So it's not necessarily congenital. There's no associated risk with the next pregnancy. It's just some really bad luck. So again, notice that the thumb is present and the radius are present. So if you start seeing thumbs and radiuses missing, then you start thinking about more syndromic stuff. So if you see an absent radius, think factor, right? That's the limb part. Absent thumb, Holt Oram. Remember, Holt Oram is one of those zebras that has association with ASDs. And then if you see an absent radius with a thumb, that's thrombocytopenia, absent radius syndrome, or TAR syndrome. So that's an uncommon one too there. So, all right, next one. Speaking of uncommon things, this is the total zebra. Occasionally will show up in case conference or case books, and basically it's sclerosis and fusiform enlargement of long bones that spares. Notice that there's sparing of the epiphysis. Would be hot on a bone scan if you happen to get one. And this is Engelmann syndrome. It's genetic. It's got autosomal dominant inheritance pattern. That's pretty much all you could possibly ever know about it. Here's another zebra genetic thing, and notice the clavicles absent, mostly absent. So this is cleidocranial dysostosis. The other thing to know about it, aside from the fact that the clavicles are absent, is that there are Wormian bones. So Wormian bones are this subset of small intersutural bones that are between the cranial sutures. And typically, if there's around 10 or so of them, then people start calling them, and they're right around the lambdoid suture, so they're found like on the back of the head, like back here. So that's your Wormian bones. So when I say Wormian bones, I want you to think about, now there's a pork chops differential. It's very long. I just want you to remember three of them. The first one is the one that we mentioned already, cleidocranial dysostosis, or the missing clavicles. The next one is OI. So anytime you're reading like a multiple fracture case and that kind of stuff, or a child abuse case, you should comment on the presence or absence of Wormian bones because of this. Like, you get into court for a child abuse case, they're going to say, how do you know this kid doesn't have OI, osteogenesis imperfecta? So it's worth mentioning that. It's just knowing that's there. And the last one is the P in pork chops, which is pycnodyssostosis. What is pycnodyssostosis? It's a bunch of different stuff, but the thing to remember is that it's basically osteopetrosis with osteoacrolysis. Notice the fingertips, so they like to show it with a hand. Fingertips out, dense bones. These kids also have a wide-angled mandible. It's a buzzword, and of course they've got Wormian bones. All right, I'll show this in a couple of different talks, I think, but it's high enough because it's syndromic, and it's like part peds, part MSK, part neuro. This is the anterior bowing with this pseudoarthrosis. This is NF1. The remember that the elephant man had NF1. So scoliosis, anterior lateral tibial bowing, and this fibular pseudoarthrosis is a classic. So let's just go over bowing. It can be from a bunch of different stuff. Several of these I've mentioned already. When is it normal? This so-called developmental. When is it normal? So when you're first born, coming out of the uterus, you're sort of cramped in there, right? So you've got a varus deformity. And if you ever see a newborn baby, they sort of sit like that. And then they start walking, and then it corrects. And then as you walk a little bit more, then they start doing this and sort of walking like they're riding a horse. So it becomes valgus. And then it corrects again around 6, and it should stay normal after that. So the take-home point is that varus after H2 is abnormal, i.e., if you see it, think about Blount's. All right, next case here. This kid comes in the ER. He's got shoulder pain. I guess what his favorite thing to do is. Not sure if that's normal or not, so you get the opposite side. And you'll notice that the physis is wide here and narrow here. I'll bet you he's left-handed. This is the so-called little leaguer's shoulder from excessive throwing. It's always nice to have the contralateral. It would be make a good next step to be able to see if that's normal or not. And this is a Salter-Harris type 1 fracture, involving the physis. All right, next case. Another sort of classic Aunt Minnie. We've got a punched out, beveled-edged, lucent or lytic lesion in the skull. Same patient has this vertebral plana. So this is LCH or EG. Remember, those are the same thing. This has a differential here. In a kid, I'd think about either neuroblastoma Mets or EG. They show you that in the skull. I guess it could be neuroblastoma, but man, that's so classic for LCH that I think that would be what you'd have to pick. It would be a very dirty trick to put that as another thing for multiple choice. I wouldn't think they would have them both as choices. All right, next case here. Let's take a closer look. Right there, boom, metaphyseal corner fracture. So that's an immediate buzzword for child abuse. Start looking around. You get your skeletal survey. Notice there are rib fractures, especially if these things are multiple ages, right? So just a quick review, non-accidental trauma. Some people just can't take screaming kids. So it's fractures of the long bones. Those are most common, although they're not very specific. More specific than that is multiple fractures, multiple ages, metaphyseal corner fracture, posterior rib fractures, especially near the costovertebral joint from like the squeeze, isolated subdurals. Here's some of the more tricky stuff: duodenal hematoma, pancreatitis. Remember, if that kid's not old enough to ride a bike or he didn't have a seatbelt injury, you should not see traumatic pancreatitis or duodenal hematoma in a newborn. If you do, that's the same as a metaphyseal corner fracture. It's non-accidental trauma until proven otherwise. So how do you work this up? Skeletal survey, you got to call the provider, of course. You got to specifically mention non-accidental trauma. Always comment on the wormy and bones. I mentioned that before because of osteogenesis, head CT, probably maybe a bone scan to look for different aged fractures. All right, so that's it. That's end of part C, and then we'll go on and we'll talk about some abdominal tumors.